Definition of the word apnea is obviously important, and you should also know what is the definition of hypopnea. But first, apnea. Well, apnea simply means absent breathing. The cutoff or duration for the same has been asked in multiple choice questions. So absent breathing effort for a duration which is lasting more than 10 seconds. That's the first and the foremost thing that you need to remember. This will be associated with approximately a 3% decrease in the saturation of oxygen in the body of this particular individual that can be measured by pulse oximetry. And then there should obviously be a cortical arousal. How would you check for cortical arousal? You would check for the EEG, the time for working out. What are the risk factors for development of this particular condition? Well, one of the most important risk factor is obviously centripetal obesity. Now, why is obesity contributing to this? Then I can divide this discussion further into two parts. Point number one would be that there will be narrowing of the lumen of the upper airway. That's obviously because of the fat deposition in the upper airway of the patient with respect to the uvula or pharyngeal wall. So narrowing of the pharynx, I would say, or narrowing of the pharyngeal inlet is one of the reasons why you would be having snoring and would be having a obstructive sleep apnea developing in this individual. The second reason would be that there would be a reduced compliance of the chest wall, the expansion capacity of the chest. You see, our diaphragm generates a force which would help you to inflate your lungs. Due to the obesity, the compliance of the chest is lesser. So the pull that is required to keep the airway patent during inspiration is hampered in this individual. I said two things: narrowing of the pharyngeal inlet due to fat deposition, that is one of the reasons. The second would be decreased chest wall compliance, which would decrease the caudal traction. Mark my words there, caudal traction, which is required for keeping the airway patent. And therefore, we are saying that there is a collapse of the airway. Upper airway does not have any cartilage. I mean, it's not a stiff area that like trachea has these cartilaginous rings which keeps it patent all the time. But in this case, due to obesity, the patency of the upper airway is compromised, and that explains the fact that obese people would be having a higher incidence of development of obstructive sleep apnea. Now I am showing you a very thin person. In this particular person, you will notice the fact that the mandible is not even properly developed. So people with craniofacial abnormalities, especially a disease by the name of micrognathia, are at risk for development of OSA because the tongue would be disproportionate to the size of the mandible. So it's obviously bound to fall backwards during the phase of sleeping, especially REM phase, where the pharyngeal constrictor muscles are not working properly and the airway obstruction would occur. Sometimes you will notice that the examiner will write the word retrognathia and sometimes they will write the word micrognathia. So obviously you should know the meaning. Micrognathia, as the name suggests, simply means there is a mandibular maldevelopment, there is a mandibular hypoplasia in the patient, which would be responsible for problems in the patient. On the other hand, when I say the word retrognathia, it means there is an abnormal mandibular position with respect to the maxilla, because our maxilla and mandible are aligned. But if you have an abnormal mandibular alignment with respect to the maxilla, WRT means with respect to the maxilla, then it implies the fact that the patient is having a retrognathia. In the next image, I have shown a syndrome here. You would definitely notice that this child, partially open mouth, protuberant tongue, mongoloid slant. These are very characteristic features that are seen in children with Down syndrome. So even children with Down syndrome have a protuberant tongue and would be having an incidence of obstructive sleep apnea, which explains behavioral abnormalities noticed in children with OSA. Then would be relatively a rare pediatric condition that's again related to mandibular and the maxilla alignment, that is Treacher-Collins syndrome. So these are two important reasons which I wanted to remember from the syndrome perspective. The incidence is also increased in women post-menopause or after menopause. That's primarily because they have documented the fact that estrogen improves ventilatory drive. So when a woman is younger, the incidence is lesser, but in a woman who's older than 45, lesser amount of estrogen, the respiratory drive is relatively lesser, so incidence increases in women. Then you can notice macroglossia with a broad nose in this particular patient with coarse facies. So I have shown here an image of a patient of acromegaly. There's a coarse facies, there's a large tongue, and the large tongue would obviously be having a tendency to fall backwards and narrow the airflow and contribute to disordered breathing during sleeping. Hypothyroidism has myxedema that can explain the airway narrowing in the individual and contributing to development of obstructive sleep apnea. During the description, you will notice the fact that most of the time I'm emphasizing on either the obesity component, obviously, which is the most common cause, or I'm rather emphasizing on the mandible and the tongue disproportionate with respect to each other, or for that matter of fact, I'm talking about airway narrowing due to connective tissue overgrowth or myxedema primarily. But I would also like you to remember that people who are having diseases, ENT diseases, like I would say a patient has a high nasal resistance. What I imply by the word high nasal resistance is that this person is having nasal polyps, big nasal polyps, or is having adenotonsillar hypertrophy. So people with high nasal resistance, what happens is because they can't breathe through their nose in sleep, they tend to breathe with their mouth open. And when they're breathing with the mouth open, again what happens is tongue tends to fall backwards. Why? Because if I keep my mouth closed at the moment, imagine if I'm lying supine and my mouth is closed, then the closed mouth will ensure that the tongue is not gonna fall backwards. But if I am sleeping and my mouth is open, then the tongue has a higher chances. So you will notice a lot of these people know later on when you talk to them, they'll start saying like, sir, I wake up with a dry mouth. I wake up with a foul breath. Why? Because if he's breathing with an open mouth, then the individual would be having the saliva would be relatively lesser, and the saliva would evaporate, and therefore the growth of bacteria can also occur. So these people wake up with a dry mouth and a bad smell from the mouth. That comes basically because saliva has bactericidal properties. So what I'm saying is that people with high nasal resistance, that is deviated nasal septum, and even polyps, could be having a development of mouth breathing in the sleep, causing the tongue to fall backwards, and therefore there could be occlusion of the airways of the patient. So these are the usual risk factors which are related with development of obstructive sleep apnea. Now let us look at what is going to be the examination findings for this individual. So on examination, when you take the blood pressure of this patient, you will notice that he is hypertensive. This hypertension could be noticed by the hypertension can cause a headache. So hypertension could have been pre-existing to the current symptoms of the individual, or could have developed subsequently. In general physical examination, you will also notice that the abdominal girth of the patient will be increased. There are charts available for that, appropriate for age. There are similar charts for neck circumference that would definitely be increased in the individual. And when you do a ENT checkup, you will notice that either possibility can be that the tongue size is bigger, or you might notice that the mandible of the patient is smaller in size or is malpositioned. That is one. Another possibility could be that the patient could be having a low-lying palate with enlarged tonsils or a bulky uvula. That's the usual presentation that you will notice in obese people: low-lying palate and a bulky uvula. With respect to children, you might notice that the child might be having enlarged tonsils, and enlarged tonsils can also contribute to development of adenotonsillar hypertrophy, as I said, can contribute to. Now we will talk about what are the treatments which are available for these patients. Usually the best treatment is a CPAP, like I have shown here a Philips model here. The person is shown sleeping with a mask on, which might be a little bit of difficulty initially because a person might have irritation to the mask. They might be damage to the nasal septum because of the rough plastic tissue of the mask. But yeah, the quality of the products is improving in our country. So this would cost about 30,000 rupees in Indian currency, and the quality of life of the individual definitely become better. So let's look at what are the treatment options available before you as a doctor for managing a chap with OSAHS. First and foremost is obviously weight loss, but that should be at least 10% weight loss that should occur in an individual to reduce the hypopnea episodes. Just to put it in the contrary sense, I want to tell you that for every 10% increase in the weight, like suppose weight is 80 kg, if it increases to 88 kg, for every 10% increase in the weight, there is a 30% increase in the incidence of development of obstructive sleep apnea. Just by looking at these figures, which is 3 times more, you can understand that whatever is the population of obesity, I mean more than 30% of them are suffering from obstructive sleep apnea. So more is the weight, more is obviously the incidence of it. So weight loss is obviously recommended. Then you have to tell the patient to avoid sleeping in supine position. That's very, very obvious. I mean, these people are anyway having a narrowing of the pharynx, which is a collapsible structure, especially in REM phase. So avoid sleeping in supine position is recommended for these patients. Try to sleep on the side. Lateral decubitus is a good idea. The third thing that is to be done for these patients is obviously, I mean, regulating sleep time is very important. That going to bed, waking up, good sleep habits is recommended. But if nasal allergy is concomitantly present, like polyps, etc., they have to be handled very aggressively, because as I said, nose resistance is more, he will breathe through his mouth. That again contributes to development of increased incidence of OSA. Avoid alcohol intake at least 3 hours before sleep. I mean, like social drinking in Western countries, no, they drink a lot. So at daytime, we'll say, okay, you can drink, but at night time, before you go to bed, don't take a drink, because alcohol will decrease your CNS drive and the incidence of OSA will increase. So avoidance of alcohol intake is also at least 3 hours before sleep is recommended for these patients. And now we come to the specific answer, that is CPAP. When would you advise CPAP in an individual? I would advise CPAP in an individual if there is more than 15 hypopnea episodes per hour, even if there is no symptoms in an individual. And I would advise CPAP if there is more than 5 apneic episodes per hour. So CPAP is recommended for both mild to moderate to severe. Therefore, CPAP is required for most of the patients of obstructive sleep apnea to splint the airway open. As the name is continuous positive airway pressure, it will splint airway open, will prevent the collapse of the airway. The disadvantage of CPAP can be manifold. One can be aerophagia. The abdomen will distend in the morning. So that's obviously a person will get used to it. And sometimes because of this aerophagia, they can be concomitant GERD developing in a patient. So antacids might have to be used in these patients. One of the surgery which is mentioned in the textbook for these patients, though less performed nowadays, is called as uvulopalatopharyngoplasty, which means resection of the uvula. So if you remove the uvula of this patient, you are creating more space, and that's what you require to prevent the collapse of the airways of the patient. So uvuloparyngoplasty is recommended for these patients to minimize the incidence of OSA. Now we have a upper airway stimulation device. It would be surgically deployed. It will stimulate the hypoglossal nerve of one side, which will cause a contraction of the muscles, especially of the tongue. So the chances of tongue falling back would be definitely reduced. So I'll mention regarding this upper airway device, which is deployed surgically. It's a surgical implantation. And the manifestations in this individual would be that it will stimulate the hypoglossal nerve. And the end result would be the prevention of the tongue from falling backwards. There are some oral devices with varying efficacy which are also available. They act by basically repositioning the mandible of the patient. They're very difficult to manage. Sleeping with something in your mouth is not something very comfortable. So oral devices which help in reposition of the mandible, the acceptability of them is also less. The efficacy of them is also very varied. So there is no valid documented study or meta-analysis available which is rather saying that this is superior or inferior, because they've actually not tested them. So they're available in the market obviously, but then the clinical studies documenting their use is not available. So the treatment of choice for this condition is obviously CPAP. Initial treatment would be answered as weight loss in an individual. Disadvantages of CPAP can be aerophagia, getting used to the device, local trauma due to the ill-fitting mask, etc. are the minor side effects that can be obviously adjusted with the help of a good post-sales team, I would say. And now the models are fairly affordable for our Indian patients. So the quality of life in these patients will definitely increase dramatically.